I want it to be a pretty big breath, so shoot right. So I'm shooting for a top line pretty close to what I have it on. So that kind of just gives you a goal there. Okay, tell me about all these other buttons that are on here, David.
So we have the flow pattern, peak flow, which changes our eye time.
Okay, so do you like your peak flow 54? Doctor doesn't write that order, so you can tweak it. What is our eye time?
188.
Okay, E time?
4.
It goes
Oh, yeah.
3.74.
3.74.
So it gives us an idea of 1 to 4. We could probably decrease it a little bit. If we decrease it, what will happen to the eye time? We decrease the peak flow. It's going in slower, so eye time will go up a little, right? We could get closer to 1. So let's do that just to see if it'll help. So now our eye time is 1. So our eye to E is 1 to 3.6. Maybe a little bit more comfortable, not going quite so fast. Okay, so we tweak that a little bit. There again, Doctor won't give you that order. You can change that how you want. What's TIP? When would we ever use that?
Trying to get like an X-ray or.
Do a breath hold. Okay. What else would we want a breath hold? Yeah, give it an inhaler. Yeah, give a little bit of a breath hold. You could do it with a nab, but your nab's going to run a pretty long time. I'd be afraid I would forget to take it back out. So I probably wouldn't do it with a nab, but you can. You can put one in if you want. What else? Yeah, those are the 10 reasons, right? Our air supply is good. Good. Take your vent out of service if your air supply fails. Well, that begs the question. If it says air supply failed, that means you're not getting air to your vent, right? So what could the problem be? The problem could be the wall, it's just not connected, so just check your connection. The other thing could be the connection to the back of the machine. Sometimes you just have to tighten these things up, right? So just tighten everything before you take that service. Otherwise, if it says air supply failed, you have to take it out of service. It means it's not getting either the oxygen or the air coming into the back of the machine, right? Okay, flow trigger, what is that?
Patient's ability to trigger a breath.
Right, and can this patient trigger a breath? I mean, they're taking spontaneous breaths, right? So we want that to be pretty easy for them. Okay, so you can default it to 5. Most of the books say 2 to 3. I think it's 5 because it's detecting it right here with this flow sensor so close to the patient. The other vents don't have the flow sensor right there. It's in the exhalation side or in the inhalation side, so that it doesn't pick it up as fast. So that's why I think they default to 5 on this vent. But on the test, probably turning it to 2. I mean, like in real life, for the boards, they're probably going to want you to do 2 liters per minute because they're not assuming you have a G5. They're assuming you have probably something else without this flow sensor right here. Okay, so I would probably just leave it at 5 and see if my patient can trigger a breath. Okay, pressure port we talked about. We talked about our flow pattern. So that what flow pattern do we have there? Decelerating ramp, right? Okay, what's the difference between, as far as patient-wise, between decelerating ramp and square? What changes would you see on your stuff if you went to square?
Kind of square.
Okay. Okay, so what changes do we see right now from going from decelerating to square? What's our eye time?
0.59.
0.59. We were at 1 second a minute ago, right? So when you go to square, it decreases your eye time. That is something to think about. If you were to go to square, I don't go to square because it decreases your eye time. Gives them plenty of time to exhale. Maybe if you were really fast rate ventilating your patient and you needed a shorter eye time, you could try it, but there again, I've never used it. It's not very comfortable for the patient. But that just makes you realize that square waveform has a shorter eye time. If you were to switch to decelerating ramp, you would have a much longer eye time. So you just want to always check that I to E. Because as we saw, we went from 1 second to 0.59 seconds. And the other thing that's going to happen when you switch to square waveform, it's going to hold that breath longer, so peak airway pressure goes up. So if your peak airway pressure is already high, square ramp's not gonna be your friend. Why do you think the peak airway pressure goes up? You can even hear it. The I time's a lot shorter, right? So it's pushing it in really fast and it's holding it. So it's like, kind of like that. So that's not real comfortable. There again, that's why it defaults to decelerating ramp, why we like decelerating ramp, which also makes volume control volume control ventilation with decelerating ramp more similar to pressure control ventilation, which is why we don't go to pressure control quite as much, because we can kind of do it on volume control since we have this decelerating ramp option. So, okay, what's our P ramp?
Like how fast that breath goes on.
Which ramp?
Or it's like,
Volume control, no,
oh.
only the pressure breath. So think of P ramp as pressure ramp. Only gonna apply to a pressure control or a pressure supported breath. It only popped up because we have pressure support. It's only gonna apply to the spontaneous breath. We already told it how fast to go with our peak flow on the machine breath. So and we told it to either do decelerating ramp or square. We already picked the waveform for the machine breath. So it only works on, if you're on pressure control, it'll work on those breaths, or it'll work on pressure supported breaths. So think of it as P ramp, pressure ramp. So only pressure control, pressure support. Remember, pressure control is the machine breath. Pressure support, that S helps us remember it's on spontaneous breaths only. Right? And so it pops up here because we can take a spontaneous breath. So you can't see, it's not going to show up on your pressure waveform here. You can't, unless your patient's breathing on their own. So if my patient were to take a breath on their own, not very comfortable. So P ramp's only affecting those breaths. It defaulted back to that. I did. Okay, all right, so fiddled with this a little bit. ETS, what is that? Sensitivity or something like that, right? So when, on those spontaneous breaths, they're again, only gonna work on a pressure supported breath. When is it gonna cycle to exhalation? So if you didn't have pressure support in, your ETS wouldn't, I don't think you can make it go around with that, but your ETS is not applying to any breath. Only spontaneous pressure supported breath is the ETS gonna cycle you to exhalation. Otherwise, if you don't have any pressure support, your patient's going below the line and above the line, they're cycling everything. We don't really have to tell it when, because we didn't add any extra pressure to the system. So if it's pressure supported, ETS is gonna be a thing. Okay, and you want to be sure your backup matches, which I think the machine pretty much does it for you now. Our backup's 15,500. Our peak flow, we went back to 54 because we didn't accept it a while ago. But just be sure your backup rate matches what you have on. Especially if you're on spontaneous breathing trial, be sure your backup, you don't use just what it picks for you, that you put it back to what you had before on for your apnea. Okay. Everybody good with all the buttons? You can explain all the buttons to me? Because that's what I'll be asking. So you put them in, see what pops up, you'll have to explain the buttons. Alright? Okay, so we got our patient on the switcher settings, so we didn't like them. Okay, so it says, put these on the vent along with other settings needed, such as backup rate, alarms, flow, I time, ETS, all of that. So we talked about all that. Let's look at our alarms real quick. Okay, so what are you going to set after you put your patient on? Because we want to set it 10 to 15 about what they're doing. Peak pressure, right? That high pressure alarm. It defaults to 40, but our patient's doing 40. So we're going to set it to 55. There again, I will be making some changes. This little one doesn't like the 530. So that makes me think, okay, if I'm peak pressuring pretty high on my patient, this is for a real life patient, I was peak pressuring and taking 51 to deliver 530, I would be like, oh no, that's not good. That's a little high, right? They're having to push really hard. Either they need breathing treatment, they need to be suctioned, they're biting the tube, or that tidal volume is too big. right? 5:30 we might be pushing our limits on that. Okay, so that just makes you think, okay, what do I need to change here? Okay, but for now, we did our alarm. Our 5 is a disconnect. Minute volume alarm, I usually 1.5 times what my minute volume is, so it's about 6, so, 10's almost 1.5 times. 3 to 4 liters at the bottom, I don't go below that. Rate, I kind of put that around what they're doing. It defaults to 23 and 8, so I want to go below 8 on the bottom because it's going to get 13 from the machine. That gives you a little wiggle room. And 23 is probably fine, they're only breathing 13. If my patient was breathing 23, I would increase my rate alarm, right? Otherwise it's going to go off all the time, so I would put it to like 28. So there again, kind of mold it around what you have. And then your tidal volume, we have 530, so 750 is pretty good, and 250 on our bottom is probably pretty good. Usually I think they just kind of leave those at what the machine takes, from what I understand. Apnea time, 20 seconds, I'm gonna leave that, unless I have a patient with weird breathing pattern, I needed to change it, but otherwise 20 seconds is good. Okay, so you put your patient on. What things are you gonna write down on your little paper when you do your vent check? You'll fill out your first page that says vent information. So the things you're going to check would be vent remains on, ambu bag at bedside, be sure you're checking that. Just put a check mark in the boxes over here. Vent charge initial, you would check that box. Vent charge data subsequent, you won't do that because it's the first day. Vent check, you'll check that box. If you did any of these other things, you would check them, but for now I'm not going to do those. Then vent ID, vent mode and model, this is going to be SIMB. No, I think that's going to be G5 and then Hamilton, actually. I'm like, oh, I want the mode right there. Yeah, so the Hamilton would be the mode. Does that say mode or made? Mode, okay. I think it's going to be G5 or Hamilton. One's Hamilton and one's G5 is what I think. Why do they even have 2 there? Because Puritan Bennett at the hospital, they have an 840 still, and they have a 980. So you would have to put Puritan Bennett 980 or 840 or 980. So in the Hamilton, actually they have a G5 and they have a C1. So you're going to pick Hamilton for one of them and then either whatever vent you have. I think there's a C3 coming out as well. And then oral care and oral care performed, you would say you did that because we do that all the time. So you'd have your first sheet there that you would fill out numbers on, and then the next one you would go to says vent only, readings, RT only. And this is where you can put your readings in. Okay, so peak pressure, what would you put for peak pressure? 50, which is what you set at 55, so we're barely above what you set at. So peak pressure, you put 50. And a ventilation, what would you put for that?
4.
Minute ventilation, it's our 6
Oh.
liters per minute. Expired tidal volume? 459. We're a little lower than what we said, right? 75, 30. Give or take 50, so we're probably pretty close. If that's too low, what's your problem? What would I be thinking? I'm trying to get 530, I'm only getting 459, and it's not peaking out at 55 right now. We set it for 55. It's not dumping the breath because it's at 50. We're not hitting 55 and dumping. So why am I not giving this tidal volume? What would I be looking for? Well, then it'll peak and dump. And we adjusted it so it's not. We're pushing 50 in there, and yes, I think that is too big, but we got a leak somewhere. Right? If we're not reaching the tidal volume we have set, we need more than 50 mils, we need to look for a leak. And on this one, I think it's actually in this little thing right here. But where are some common places we would have a leak? What's the first thing I'm thinking of? Cuff pressure. What's my cuff pressure? Am I leaking around the cuff? That's the most common leak. Otherwise, yeah, just start looking at your connections and being sure everything's tight and snug. The other thing, your inline suction right there has that little place to put saline. That little cap is sometimes off. So check that as well. So check your connections everywhere, make sure everything's connected. The other time you'll see that, so you're leaking somewhere, right? So yeah, let's check our cuff pressure, let's check our connections for loose connections anywhere. And so if they have a chest tube, sometimes you will have a leak out the chest tube that you're not recovering back. It's leaking into the pleural space and hanging out there. So you may be losing some volume there. So if you're not getting back what you put in, you've got to investigate it, right? You should. You should get out what you put in. And especially on these vents, what you'll see at the hospital, this is the weird thing. You're set for 530 because it measures it right here. Sometimes it measures a little extra that's hanging out in this circuit. So you'll be putting in 530 and getting out 540, 550. You're like, how am I getting more out than I put in? Where's this coming from? It's because it's kind of staying in this dead space area and it's measuring it so close to the patient. So more on the G5, you're going to see over instead of under. Okay, all right, does that make sense? All right, so exhale tidal volume. Spontaneous tidal volume, only if they're on SIP or CPAP. This patient is on CPAP. Do they have a spontaneous tidal volume? They only breathe. They're set for 13, breathing 13, so they don't have anything spontaneous. But if they did, they're breathing on their own like they did right there. Oh, it's a little tiny one right there. It was 162. Okay, so after it shows up here, you'll see that it's smaller in the little triangle. It'll be over here. The next breath is often where you see that number. So look, you saw that it was little, so look over here for that little number. Like I'm not going to put 466. I saw that it was smaller, so you got to be sure you're kind of quickly looking over here to see what you're going to write down, right? So there we took another one. Took another one. It was 139. So after you see it here, the next breath it'll show up there. It takes a second to record it. Does that make sense? Okay, so look for the small number. All right, so this patient did have a spontaneous breath, and it was 139. That's where you would write that. Rate total. Okay, they were breathing set for 13. They're breathing a couple more than 8. They're breathing 18 over there. So they're taking a few little breaths. IE ratio. You might have to go back to either controls or monitoring, and you'll see it. 1 to 3.6. MAP, where are you going to find that? What does it stand for? Mean something. Mean airway, mean blood pressure, right? In this case, MAP is in mean airway pressure. So, P mean, pressure mean, 13. Okay, we need to do a plateau pressure. Everybody remembers how to do that? Go to tools and hit that inspiratory hole, and you'll see it in yellow. Okay, so we got our plateau pressure 43. It's going to always be less than your peak. Our peak was 50, that one's 43. That's a big number, right? That would also prompt me to make a change in mode, probably, right? Or tidal volume rate, right? What do we want to keep that under? 43, so that's a little too much, right? Well, our patient's got some really stiff lungs, they're going there. Okay, and then alarms. You'll just go to your alarms and set those and then write those in. Alright, so that's doing just a basic check, which we would do. And then last, we'll go to our TSB wing page. After you make a change based on the blood gases, eventually we'll wing our patient on. So that'll be the things we fill out the front page, the vent check page, and the TSB wing information. All right, so you're going to kind of write that in. Okay, so we got our patient on, and we draw blood gas. They've been here for a little bit now. Draw an ABG. Our pH is 7.50. CO2 is 30. PO2 345. Base excess 26. ready to come up with something? Alright, what would you like to change?
So we could either change the rate or the total volume. If we change the rate, we go down to 10. And if we change the tidal volume, we go down to 4.
Okay, good, okay, so you can change either one, right? In this situation, I'd probably change tidal volume just because it's so tight. But if weren't looking at that, yeah, you go to a rate of 10, right? Same math, known times known divided by desired, you can use the same formula for both, right? And then FiO2, would we want to change that?
Go down to 80.
Yeah, go down to 80, really quickly go down to 60, right? 21 minutes, good. All right, good, okay, so you've done initiate, we've got an A to G, we've made changes, we've put in all of our settings, we've done event check, we know how to do that. Okay, so you come back in 2 days, and your patient's, it's not doing great. Next day you come in and her pulse ox is reading 90 on the same settings. Our plateau yesterday, we're pretending, was 26, even though ours was 43. And now our plateau is 32. You suction your patient, you don't get anything. She's very sedated. There's no kink in the tubing, there's no secretion, she's not wheezing. Heart rate's 104, respiratory rates with the vent. What would you like to do now? What do you think is wrong? What do you think is wrong? Plateau pressure went up and SAS went down, right? Or yeah, oxygen went down.
Losing.
Probably losing compliance, right? So, unfortunately, she is probably from that big tidal volume at the other hospital. They caused barotrauma, and now she has ARD. Okay, yes, so we think we have a compliance issue. So what would you want to try to fix that? We'll pretend like we're back on 100%. Couple of ways you can do it. What would David do?
So it started lowering her tidal volume.
So lung protective, looking at lung protective, right? So so if we lower the tidal volume, what else do we need to do?
Increase the rate.
Right, okay, so lower tidal volume, increase rate. And what's our minute volume? You want to probably note that in your head because we're probably shooting for that same minute volume, right? Which is 6 liters right now. So lung protective is, yeah, low rate, high rate, low tidal volume. Keeping about a 6 liter minute volume. So we were 8 mils per kg a minute ago, so what are you going to? 6 mils per kg, okay. So what are your new numbers? Okay, those numbers.
395 the tidal volume
Okay.
and increase the rate to 15.
Okay, so you used your 6 liters, your 6,000 mils for your minute volume. You figure your 6 mils per kg, and then that came up with your, divided that minute volume by that new tidal volume, got your new rate, right? And then figure out, remember how to do all that. Okay, let's do it. Anytime you make a rate or tidal volume change, what do you have to check?
90.
IE. Okay, so we've got 1 to 4.2, I times 0.77. This is where when they have really stiff lungs, it's probably 0.77 is about all it's going to take to fill those lungs, but you can increase that to 1 second if you wanted. It gave us 47 liter. We still have a 47 liter peak flow. You can adjust that if you wanted a longer I time. Probably be okay at 0.77 truthfully, but you can adjust it if you wanted to. All right, so that's how we would address the stiff lungs, right? Now, our oxygen is still low. It's got the same minute volume, we just are doing it a little differently. So how are you gonna address low oxygen?
Increase the P.
Increase our peak, right? Okay, so be careful with that. We do have a lower tidal volume, so it probably should be okay, but what would you increase your peak?
7 or 8.
7 or 8, yep, 7's fine, 8's fine. 2 to go up by 2 to 3. And what are we monitoring when we increase the peak? Oxygenation, obviously, the SAT. What else? What are we afraid of when we increase the PEEP across the chest? I'm probably going to make that mistake. If we don't give them time to exhale, we have more out of PEEP. We don't know that it's not a COPD patient.
Airway pressure.
Huh?
Airway pressure.
That should go up. We're expecting that to go up because we increased the PEEP. We've increased the pressure across that whole chest for the whole entire cycle. Is that going to decrease? Coming back to the heart. Venous return, decreasing venous return, which decreases cardiac output, because if we can't bring it back to the right heart, we can't push it out on the left heart, which means our blood pressure is going to drop, right? So anytime you make PEEP changes, be sure you're looking at your patient's blood pressure. So we increased our PEEP, Gracie, and we're monitoring blood pressure, right? Sometimes go from PEEP. Maybe that's good. Okay. All right, y'all good? Okay, so our patient did poorly. We addressed that. So that's kind of our RSNP protocol. It's where we change that tidal volume and rate. We could make another step change as well to 4 mils per kg, but we're gonna leave them right here. Another option would be what? And we can still do it even with these changes that sometimes helps with ARDS. That we like to do sometimes.
Proning.
I like a prono. What on our modes, what else could we try? We can inverse ratio, we're not doing it too much. What's a little more comfortable for our patient, a little more lung protected?
Oh, the body control plus.
Right, VC plus, right. It's a pressure control mode, right, with the targeted tidal volume. So a lot of times when we make these changes, we'll also switch them to VC plus, but what's it called on this one? How would you get it? Yeah, APV, CMV, or SIMV. We were on SIMV. Patients that get sicker, we usually switch them to assist control because we want every breath to be big. We're not really wanting them to be doing a lot on their own. Yeah, so we go to your APV, CMV, right? that's VC plus on this vent. So our volume targeted rate mode. Okay, everybody good? Okay, we got them on volume targeted. Trying to protect those lungs. They do better. They're doing better. We come back in 3 days. The doc says, I think she's ready to come off the vent. Can you get some weaning parameters for me? And he said, yes, I can. What weaning parameters are you going to get before you put them on spontaneous breathing trial? You want to get a few weaning parameters, right? What are those and what are normal values? What are the most common weaning parameters? Say again? Driving pressure would be more when we're lung protected, when we went to increasing that peak and the peak airway pressure or plateau pressure, that would be our driving pressure. So we're looking at that more during having trouble, not so much a weaning. parameters we were done?
Total volume.
Total volume, right? What's our total volume need to be? 5 mils per kg, yeah, so you would put that pressure support down to 5. That would be, after you put them on spontaneous, you'd be looking at total volume, right? At least 5 mils per kg. What else? Respiratory rate less than 35, yeah, depending on your protocols, 30 to 35. What else?
Vital capacity.
Do a vital capacity. How do you do a vital capacity? Put them on spontaneous and tell them to take a big breath and see what it is. Get that pressure support down to 5. Otherwise, that extra pressure support make them take a bigger breath. So turn the pressure. That'd be a spontaneous one. What else can we do? So vital capacity. Tell them to take a big breath and see how big it is. There again, put that pressure support down to 5. You want to put them on spontaneous. So total volume, vital capacity. Things that we would also be looking at before we even started. What are some of the other parameters before we even do these things? FiO2 down to 50 with a PaO2 greater than 60 at least, right? So that looks good. And PEEP's already down to 5. We've already moved our PEEP down. What else? Yeah, minute volume. When they're on their own, less than 10, so that'd be on the spontaneous one. What are we looking at on the monitor over there?
No, as in given to our heart rate.
That's good. Heart rate, when we put them on spontaneous, doesn't go up. But before we ever even start, hemodynamically stable. What does that even mean? Our blood pressure's good on minimal pressors. You have to get those pressors down, right? What are pressors? What does that even mean? Keeping the blood pressure stable. So what are the names of some of those? Vasoconstrictors a little bit. Try to keep them up. Dopamine, most common one, dopamine. Dopamine's used as well. Levophed is a potent vasoconstrictor. So Levophed needs to be darn near off, or probably off, before you would wean. So they have to have minimal blood pressure medicine support. So the names of those, dopamine, dobutamine, Levophed, those are the most common ones. Those are to get the blood pressure up. If we're trying to get the blood pressure down, that's going to be nipride. Nipride is the most common one to get the blood pressure down. How do you know they're on nipride? It has a little trash bag over it. It can't be exposed to light for very long. It'll say nipride, but it has a little tiny black trash bag on it. There's a couple of things that can't be exposed to light, so look at it. But that's one of the clues. You're like, oh, is my patient's blood pressure really high, and we're getting it down? There again. You want their blood pressure to be in normal range before you start all this without extra help. Your caveat to that is going to be your cabbage. Sometimes they're still on quite a bit of pressors because they're still working on it, but we want to get that tube out still on those patients. We know we have to manage those for a little bit, so those patients are a little bit different. But for the most part, yeah, they have to be hemodynamically stable on minimal amount of pressors before we wean. So we're looking at that. Okay, so then we said our reading parameters. We said total volume, rate, vital capacity, minute volume less than 10 liters per minute on their own. So if they can, what's the other one that we do on everybody? NIF, yeah. How are you going to do the NIF?
That's a little, yeah.
A little tube right there, right? So how do you do that? We happen to have a handy dandy ET tube for our patient. Your patient's laying there like this. So what would you do with that?
So you hook it up and tell them what we're doing, right?
Which is?
They're gonna inhale or take a big breath. 3 to 10.
Are they going to get in the air at first?
No.
No. Remind them you're not going to get in the air at first. They're going to freak out. And then their blood pressure's going to go through the roof. And then they're going to start coughing and gagging and throw up and aspirate. And then you have to start over. Yeah, you're not going to get any air for just a minute. I need to see how hard you can suck for air. So suck really hard. So that's how I explain it to them. Okay, yeah. So you're going to tell them what you're going to do, okay? And you say on the count of 3, take a big breath. 1, 2, 3, and cover the hole. So I'll go ahead and take them off, put it on. 1, 2, cover the hole on 3. Hopefully they can understand what you're counting or that they do it at the right time. It's a little tricky. As soon as it starts pulling, don't be like, come on, come on, and keep the hole covered. Because you just got a little bit more. Remember, they're not getting any air. It's not like they can breathe through their nose too. It's not going anywhere. So yes, only cover it for a second and then let off. Let them catch their breath, and then you can do it again. If you didn't get a good number, you're not sure it's good, you didn't time it right, usually you have to do a couple of them. Sometimes I'll even put them back on the vent, let them catch their breath a little bit, and then take them off and go 1, 2, 3. So take a breath and kind of coach them through it that way. So I usually get a couple of them. And what's our minimum? -20, at least -20. Really, we want more than that. What's normal? Yeah, -80 to 100 is normal, right? We only want -20 to sound a lot. Okay, so yeah, so you take them off, put your little minute thing on there, look for that number, put them back on, then I put them on spontaneous, do my vital capacity, my tidal volume, my respiratory rate. So if I'm doing those weaning parameters, I'm probably gonna get my numbers off and stuff up there, check the hemodynamic stability first, make sure all that's good, check eyes and nose, take a listen to them, be sure they're ready to do a weaning trial before you do these numbers. And I'm going to get my NIF because they can still be on the vent when I do that. And then everything else, I'm going to put them on a spontaneous. Well, the other things with my cabbages especially, can you squeeze my hand? You know, can you lift your head? Can they, are their muscles working pretty well? Did they have a gag or cough? Those are just some basic things that we would even look at before we started, right? Once we started, yeah, they put them on spontaneous, get a tidal volume, respiratory rate, a minute volume, a vital capacity. Those are the 4 basic things we're getting, right? If all of those are good, I'm going to tell my doctor, hey, everything looks good. We're going to get a blood gas in about 30 minutes. That blood gas looks good, then we would extubate. Got to check the blood gas as well. You want them to be on usually 30 to 45 minutes of a spontaneous breathing trial before we get the blood gas, not more than 120 minutes or 2 hours. And the book says 30 to 120, so usually after about 30, 45 minutes, you get my gas. And you know what your gas should look like. It should be in normal range, right? Once they're COPD, then the pH should be normal. The other stuff may be off, but your pH should be in normal range. If they're breathing really fast, we would expect them to be hyperventilating themselves. So if they're breathing fast and their CO2 is not a little bit low, we're concerned that they're breathing fast just to keep that CO2 normal, and that if we pull that tube, they're probably not going to do that well. So blood gas needs to be in normal range without a high respiratory rate. Other things that we want to manage and make sure are good: anxiety level, pain level. Be sure they're chilled on all that. Be sure they're on a sedation vacation, and obviously no paralytics, so don't fail all your tests. Take a deep breath. Nothing. They got nothing. So obviously you're good with that. All right. What are the ways we can wean our patient if we needed to do a little longer wean? What are the ways to wean listed in the book? You can do a pressure support wean where you have them on high pressure support and you slowly take it away. Pressure support wean, you can do spontaneous breathing trial, just spontaneous breathing trial with 5 of feed and 5 of pressure support, your basic way. What's another one? Yeah, SIMV. We have them on it now. Meaning SIMV, and then you slowly take the rate, then you slowly take the pressure support. So yeah, slowly taking that rate away is a way to do an SIMV as well. And you can do a fast SIMV wean too, but I'm thinking if you're long term, it's usually a slower SIMV wean. So those are the ways. Good. All right, what are things that would tell me my patient did not pass my spontaneous breathing trial? Tidal volume is too little? Yes. Vital signs. What are my vital signs going to look like? Tidal volume is too little. Respiratory rate is too fast. Those are the most common ones. Increase in heart rate by 20% or more than 20. It's about 20 beats, right? Heart rate more than 140 is the bad problem. What about blood pressure?
90 to 180 systolic.
Yeah, too low or too high, right? Over 180 or less than 90. We want one extreme or the other, right? So check that blood pressure. What else? Looking at my patient. I'm looking at him. What does he look like? My machine can tell me that everything looks good, but I need to look at him. What does he look like? What are some signs that he's doing poorly? Accessory muscle use, yeah. increased work of breathing as evidenced by accessory muscle use, and what was another one that's always bad?
Diaphoresis.
Diaphoresis, yeah, that cold sweat. They're breaking out in the sweat, they're not working, it's not hot. Yeah, diaphoresis is another sign that your patient's not tolerating. Mental status change, right? They're getting a little more confused. They kind of go, generally on the vent, you can't tell they're confused because they're not answering a lot of questions because they can't talk. They're looking real sleepy. A lot of times they'll be like going in and out. You're kind of like, okay, your CO2 is probably climbed up again, so we're gonna stop this wean. So those are things that you will be documenting that your patient did not tolerate the wean. Good. All right, so now you have put a patient on, you've made changes, you've looked at all your numbers and explained them all to me, and now you've weaned the patient off. Okay, and you know where to write your things on your paper. So when we do the checkoff tomorrow, I'll give you a scenario, you'll put your settings in, you'll do everything yourself, I'll give you time to do all that, and then I'll come check it. You'll write it down on your paper, all your initial settings and everything, and then I'll check everything. I'll ask you questions about the buttons, and then I'll give you a blood gas. Or a scenario, your patient's doing badly, or they have this is our new blood gas, what would you change? You'll make some changes. Your patient's obviously gonna do badly, so you're gonna need to go to the low rate, low tide of iron, high rate thing. It's pretty much what we do on everybody in ARDS. And then they're gonna do better. And then you're gonna have to tell me how you're gonna wean them off, what those parameters look like. So vital capacity, put them on spontaneous, tell them take a big old breath and blow it out, see how big it is. You're gonna see it right there, right? That's where the exhale tidal line is. Normally we do a vital capacity on our patient, and they call that a PFT. They say you can do a pulmonary function test on your vent, and I'm like, well, you can, but through a straw, that's not really fair. But it is still considered pulmonary function testing. Your NIF, you would take them off and put them on that little thing. Everything else you can get while they're on the spontaneous breathing trial. So how do you go to spontaneous? Hit your modes, hit spontaneous right there. Hit continue. And then your peak is going to stay the same. You change your pressure support to 5 and your peak to 5. Obviously your oxygen will be down as well. And hit confirm. Be sure you know how to go to that. I'm not going to confirm. I'll have to stay here. Any questions?